screen with you again and try to get up our PowerPoint slides. Right. Oof, keep on doing this thing of, right. Okay. Pete, do you want to go for it?
Okay, brilliant. Thanks, Annamaria. Okay, so welcome back, everyone. I hope you've been hydrated and everything. And also just a quick mention to Adam McSweeney, who's kind of in the background for tech support. So he's staying with us throughout the whole duration. So thank you very much for monitoring everything. Okay, so the first part of our project was to explore how a mix of AI developers and healthcare professionals, including a biomedical researcher, are developing 3 AI algorithms for the early diagnosis of PH, pulmonary hypertension. And we conducted interviews with them on how they went about doing this. When we started to analyze the transcripts, we became drawn to the ways in which their collaboration de-troubled transparency issues. Next slide, please, Maria. So the number one problem in healthcare AI is transparency, and a major reason why we have transparency issues is to do with the black box problem. And by now we should all be familiar with black box concerns from the literature. And this one from Shortliff and Sepulveda is a particularly good one because it highlights how a lack of transparency on how algorithms analyze data or how algorithms come to a result is or will be particularly problematic for clinicians. However, what our research shows is that when you have collaboration with clinicians during a development process, you actually have a process which de-troubles transparency issues. So if you have a close collaboration between AI developers and clinicians, and also in our case, a biomedical researcher, the algorithm is no longer mysterious or seen as a black box. To help us describe this de-troubling process, we've borrowed the notion of operational logics from Wardrip Fruin in the game studies literature, who argues that operational logics is a strategy used by developers to bridge between the technical capacity of the program and the forms of representation that are more accessible to the user. When software is constructed according to the principles of operational logics, users are able to engage critically with the program. So for Wardrip Fruin, operational logics comes in at the end point of the completed software application, where at the moment of using it, users, or in this sense, gamers, are able to understand some of the logics or principles of how the software functions in order to critically engage with it. So for example, when we play games, they actually communicate their own mechanisms to us for general game playing, such as safety and progress checking, parameter controller synthesis, and we're able to recover details about how the game behaves through logs or interaction histories and so on. However, our research shows that collaboration brings into play a comprehension of the operational logics of the algorithm during the development process. So they get to understand how it works by being involved in building it. And we argue that this is a process of de-troubling transparency, and we're going to show how it's done in 4 different stages of algorithm development. Now I'll be talking about 3 of them, and Annamaria will then talk about the other one. So the next slide that you just had, Annamaria. So excellent. So the first aspect of de-troubling transparency begins by engaging clinicians and biomedical researchers early on in the task of querying the quality of the data sets and determining whether diagnostic codes such as ICD-10 codes are accurate or precise. In this quote by the biomedical researcher, we can see how querying allows him to become familiar with limitations of the data set, which often includes tasks of recoding or relabeling. It's not the most well-defined, carefully curated data set. As long as you go on using it with your eyes open and know the limitations of it, then it's fine. The second aspect of de-troubling transparency continues with AI developers engaging clinicians and biomedical researchers in the building of the software. This is where AI developers targeted popular off-the-shelf software packages that use common statistical techniques which were familiar among clinicians and biomedical researchers. Now, this had the added benefit of allowing clinicians to refine or tweak the algorithm themselves when it came to future implementation through supervised learning and selecting additional variables that were important for identifying or excluding individuals with pulmonary hypertension. So here we have a biomedical researcher describing a software that he was already familiar with to help build the algorithm, and ultimately showing how AI developers use software and statistical techniques that people already knew. At this stage, everything has been machine learning based approaches. So using machine learning tools, that's standard off-the-shelf tools. In our case, we're using XGBoost, which is a popular and powerful package. The third aspect of detroubling transparency issues occurs when clinicians are further integrated into the development process by participating in the training of the algorithm. This quote by the data scientist working with the clinician and the biomedical researcher in developing the screening algorithm shows how she needed to draw on her clinical collaborator as a source of information and explication into training outputs that seem strange and suspicious. What can I solve myself by looking at the data? And then what can I raise to the clinician to say, this looks kind of strange? And interestingly, the reason why these outputs were seen as strange and suspicious was because they were, in the words of the data scientist, too good to be true. So just to reinforce our point, operational logics doesn't come in at the end. It comes in at the beginning and plays out throughout the development process. And at the same time, hooking back into our original theme that we began earlier, we see how in terms of offering an understanding of what's going on, the shaping of their understanding is socio-technical. So it isn't just a matter of the algorithm doing things by itself. It's been highly trained and contextualized by the humans involved in the development process. And this socio-technical theme actually carries on in the crucial question of validation and the role of validation in setting up trust. And that leads on to Annamaria's presentation now.
Thank you, Pete. So validation, really, we're talking about it last, but actually, in a way, it comes first. It's the thing that has to be considered right from the outset. Validation often stands proxy for trust, not only in AI technologies. It's a very common term used in the demand for quality assurance in science and technology in many, many different domains. And trust is one of those things that always brings in social relations. It always seems to be outsourced onto something else, the technology or some kind of technical fix or technical way of knowing something, but actually there are always social relations involved in trust. It's not that validation is not scientific, but it does mean when that validation has to be addressed to those who need to be convinced, to those who need to trust. And it must be conducted in terms that they recognize or that they share. So, for example, it stands to reason that if medical practitioners are being told that an AI algorithm can perform a task as well or better than they can, the criteria for evaluating the performance of the task must be recognizable to them and that they are criteria that they can relate to. So we already saw an introduction to this event when we looked at the very low numbers of publications that are collaboratively co-authored across clinical and computer science divides. We already saw that it's quite possible for computer scientists to publish quite respectably without really having this collaboration. They can have loads of paper in that way, of papers published in that kind of way. But our informants in the project, our computer science and data science informants, told us that when they do collaborate with clinical researchers and practitioners, their work is anchored in real-world clinical context and gains in meaningfulness and interpretability. And that means that it's not just it's not abstractly an abstract concept, a prototype in a computer science world, but it actually starts to gain a kind of meaning of how can it be interpreted in a real world clinical context. So it becomes anchored there. So one reason for this is that clinical collaborators ask questions that the computer or data scientists do not think of. A clinical participant in our research described the way in which they interrogate the results of a validation test in the same way as they would interrogate other aspects of clinical experience, such as a patient's reporting of symptoms. That doesn't mean necessarily that they disbelieve patients, but they hold in sight that the reports of patients can be partial for many different reasons, and they can be misleading for many different reasons. Another data scientist described how important it was for growing trust that the collaborators should go on a journey together from the outset. And here's a quotation from that informant. So, what can I solve myself by looking at the data? And then what can I raise to him to say, this looks kind of strange? So, yeah, and I think that's what's hugely valuable is if you can have a clinical expert to be part of the development procedure. I found that to be just priceless because he and the team, they saw all of the things that we did. They saw when we were worried. They saw when we were like, no, this actually looks okay now. And I think you can't put a price on the value of that in growing trust. So validation of this type when it's undertaken in this collaborative way from the outset, it builds up a kind of shared repertoire of the criteria and terms of comparison that will be used to evaluate the algorithm and to compare performances. That is, performances of different runs of the algorithm and comparing performances of the algorithm as against performances of humans involved. So that in this process, as you're collaborating across the different tasks that Peter has already described, in those processes, you start to negotiate these criteria and terms of comparison, which become the criteria for validation as well. So validation, we're saying, is jointly produced by collaborators throughout the process. It's not a standalone test at the end of the process of development, but it's a process that begins from the outset with the teams agreeing on the questions and on the goals together and on what counts as success. As a process, it continues through each of the collaborative tasks and activities that we described before. At the core of the collaboration is the creation of a shared understanding of the functioning of the algorithm, properly contextualized in clinical expertise and experience. And this whole process, undertaken collaboratively, simultaneously builds up the robustness and relevance of validation tests for their clinical contexts and the trust of all concerned in the results. No part of the process is completely transparent from end to any one of the collaborators, as each sees with their own expertise. However, ultimately, collaboration brings a gain in transparency as understandability in that sense for all concerned, which is distributed across the whole human technological system. So finally, we hypothesize on this. I'll just go back there. Finally, we hypothesize on this that collaborations that include clinical end users in the process of development stand a better chance of reaching prospective clinical studies, not least because the clinicians that are involved become champions of the AI application, forging a path for them to become at least candidates for the kinds of clinical studies that will bring them to a full validation. So with that, I'll turn again to Pete, who will talk about the last part of our study.
Brilliant. Thanks, Annamaria. Okay, so the last part of our project, and this is essentially Article 3, was to explore the issues relating to responsible research and innovation in a framework that most of you will be familiar with Jack Stilger and Richard Owen. And we conducted this through a foresight workshop with healthcare professionals and AI developers, and then a focus group with patients. And a director of the patient group, Pulmonary Hypertension UK, was also present at the foresight workshop. However, we only have time for a very brief overview of our main findings. So, okay, so overwhelmingly, there was agreement on the priority of early diagnosis, where the benefits of having an early diagnosis are felt to override almost all potential risks, as shown in this quotation. There's a unique situation with pulmonary hypertension because it's so rare. The length of time for finding a diagnosis is, in my eyes, horrendous. And that's just fact. Whatever they have to give up to make that diagnosis happen quicker is an acceptable cost in my eyes, and I'm the carer. However, there were also points of disagreement. For example, while the foresight workshop was enthusiastic about the potential of using AI to make early diagnoses of other conditions on top of PH, patients in the focus group were more hesitant or more negatively disposed to this because they already had enough to deal with and wouldn't want more worries brought on by more testing. In this, however, there may be a skewing of results because this group already had a diagnosis of a serious condition. So further research is needed of different patient groups with different diagnosed conditions. Another point of disagreement occurred with when healthcare professionals didn't think it was necessary to disclose to patients that decisions about their diagnosis or treatment were partially derived from AI. Contrary to this, patients actually wanted to know whether the AI had a role in diagnosis. A further potential disagreement between professionals and patients was in the expectation regarding the understanding of clinicians when they use the AI. While all agreed that the AI should have only an assistive role and that no decision should be made by the algorithm alone, patients seemed to demand a greater level of understanding than the professionals demanded of themselves. The healthcare professionals drew the analogy with MRI scans, of which they have limited understanding but still use. But in the patient group, some participants expected clinicians to know how the AI came to a decision, and they connected this to the way that clinicians develop in their profession, asking, next slide, Annamaria, how would I learn as a clinician if this AI is taking over all this diagnosis? How would I learn and grow as a clinician if I couldn't interrogate it? Next slide. Thank you. So this brings us to our last point concerning the skilling and de-skilling of healthcare professionals. And as we have stressed throughout, clinicians and other healthcare professionals bring their experience to the development of AI, anchoring it to the real world clinical settings. However, these settings will change as AI becomes more ubiquitous. And this will also change the experience of clinicians, and it will also change their training. So we suggest that the initial and ongoing training of clinicians and healthcare professionals needs to take into account shifts in skill sets and experience brought on by the increasing use of AI. And thank you, that's the end.
Right, so just to sum up there, what we focused on was this collaborative nature of AI development that's anchored in real-world clinical settings, and we've shown that there are 4 tasks or aspects of the development process that are the focal points of development, and that of the development process. And they're the focal points for collaboration to occur. And then when collaboration occurs across on these tasks, you have an effect of detroubling transparency and of building trust and acceptance, which are really implicit behind any demand for validation. So we've tried to stress that this social nature of AI technologies that are designed for clinical settings. In our research, the developers of the different AI applications were sensitive to its context of use from the outset and reaching out to it, trying to anchor themselves in it. And that means that they had to form relationships with people, with but among people with different forms of knowledge, know-how, purposes, institutional constraints, and using different technological capacities. And that also propelled the development towards creating shared understandings and towards co-creating criteria of assessment and evaluation. And that's the at this point when we're watching this collaboration in action, we asked this question about whether is this AI really a purely artificial thing? And we think that it's not a purely artificial thing. And we think that a reframing of AI as an intermingling of human, social, and technological intelligence might result in a more easily embedded and useful medical AI. So that was our project, and with that, we will go to Federico's.
Yes.
Federico,
You see me?
yes. So,
okay, great.
Sorry, just one.